The moment you've been waiting for. The pride of Rochester, New York, Mark Oldham is here to teach us about catatonia. True story, in 2023, while creating Season 2, I was feeling a little burned out balancing residency and the podcast, and I was not sure if I was going to do another season. I really believe in this project, but it takes a ton of uncompensated time. And by the way, I have introduced podcast partners this season in the hopes that I can pay someone to do the editing and production work and keep this project going. And I've been really intentional about those partners. So thank you for understanding and thank you for supporting me in this project. But back to 2023, I'm wondering if I'll stop after Season 2, and I recorded the episode with Dr. Oldham, walked upstairs, and immediately told my spouse that I am just going to have to find a way to do Season 3, because I think this is the smartest person that I have ever talked to, and I cannot pass up the opportunity to talk to him about catatonia. My friends, our conversation did not disappoint. In this first of 2 episodes on catatonia, we are going to discuss diagnosis of catatonia and talk through different ways of assessing it. We tried to distill this down to a level that is helpful and approachable for healthcare workers of all disciplines in multiple areas of training. And I left the conversation having learned so much, and I'm sure that you will have the same experience. So, without further ado, welcome back to Psychiatry Bootcamp, Dr. Mark Oldham, and I'm so excited that you're joining us. Psychiatry Bootcamp is brought to you by Simple Practice. Simple Practice makes documentation, running your own practice, managing patients easy, and it now has an AI-powered note writing tool integrated within the EHR. So it's a true all-in-one EHR that is HIPAA and HITRUST compliant and has AI-powered documentation embedded within the health record. It also has PDMP checks integrated within the portal and really easy to use lab order templates. Simple Practice saves you time so you can focus on what matters most. Psychiatry Bootcamp listeners get an exclusive 30-day free trial of their AI note taker software and a exclusive 7-day free trial and 50% off of 4 months for the full Simple Practice EHR. Visit simplepractice.com/bootcamp to learn more. That's simplepractice.com/bootcamp. Psychiatry Bootcamp is brought to you by Beat the Boards. So really excited to bring you a ridiculous deal from Beat the Boards. It's not a discount. It's completely free. Free access to over 4,400 exam stock questions for USMLE Step 2 and free access to over 4,500 questions for Step 3. Completely free for Psychiatry Bootcamp listeners. Don't miss this opportunity. Go to beattheboards.com/bootcamp to get started today. I'll tell you that I use Beat the Boards to study for my own exams, and I really found that it made the exam very doable on exam day, alleviated some anxiety, and left me well prepared. Give it a try, completely free. beattheboards.com/bootcamp. Welcome to Psychiatry Bootcamp, Dr. Oldham. We last recorded about a year ago, and immediately after we hung up, I walked upstairs and my wife said, "How'd the recording go?" And I said, "Unfortunately, I think I have to do a Season 3 because I have to have this guy back on to talk about catatonia." And I'm so excited that here we are. I'm absolutely amped about this episode. And thank you for coming back.
I'm looking forward to it. This will be great. Catatonia, it's almost like 2 different children. You love them both equally, delirium and catatonia.
A beautiful analogy there. I will ask you to give your sort of professional introduction for our listeners.
So my name is Mark Oldham. I'm a consult psychiatrist at the University of Rochester Medical Center. I'm an associate professor currently. The president of the American Delirium Society. And my clinical work currently is kind of focused on proactive psychiatric care. So I'm the medical director of Prime Medicine here at the Strong Memorial Hospital.
So we're here to talk about catatonia, and last time was delirium, and I think that they're similar in the sense that they are both impossibly broad topics to cover at bootcamp level. So I appreciate you being game to come and give this our best shot. I've noticed that a lot of your work focuses on delirium, focuses on catatonia. Want to know why? What initially piqued your interest in catatonia? What is it about catatonia that you find so endlessly fascinating that you will sit through hours and hours of meetings just to sort of make the things happen that you need to study catatonia, et cetera?
Sure. So, I was originally introduced to catatonia. I want to say in kind of a major way in my fourth year of medical school. I was doing an away rotation at MGH in their psychiatry department, in their psychiatric emergency department, and there was a patient who had hyperactive catatonia, and I was just transfixed by um, the kind of the disturbance of will or disturbance of volition. This person, behaviors at the time were very bizarre, and it was totally out of character. And they received lorazepam, and it cleared, and it was amazing. And I just remember just being, again, just kind of taken by the condition and the responsiveness of this condition to such a simple intervention. And like delirium, catatonia sits in this fascinating kind of hinterlands between the brain and the body, the mind and the body. It is this mental disturbance that leads to a rather dramatic behavioral phenotype that we can recognize, we can understand, we can seek to understand it better, and for which we have a variety of different treatment options right now.
Beautiful. I can see that picture of you as a fourth year medical student, and that eureka moment of in another world, this negativism is just labeled as willful, not following directions. This agitation is because the patient is aggressive in some way, and the treatment is completely different, and the outcome is drastically different. So I could see where when you have that eye-opening experience early on, you would want to spend a lot of time making sure that this diagnosis that I think a lot of medical professionals don't know much about, hardly anything about, never gets missed because if you become adept at recognizing it and managing it, not only can you improve the quality of people's lives drastically, but I think also save lives, as we'll talk about.
Completely agree. And throughout my training, I just remember, in residency and fellowship, I would very often say, I think this person has catatonia. And we'd review it as a team, and some people would say yes, some people would say no, and there was these kind of differences of opinion. And we're like, can we just try a dose of lorazepam and see? And so many of the people got better that it was just like, I bet it's here. I bet it's just kind of lurking. We're just not picking it up.
Very validating for me to hear that, and I'm sure for our listeners too. Um, Before we really dive into this, is there any further reading that you want to point our listeners to if they're listening to this podcast and we pique their interest and they say, is there a really good document that I can go to learn all about this? Where would you point them?
Sure. So there have been a couple of really, I say, just excellent publications the past few years. It's really delightful to see, kind of encouraging to see that there is an increased interest in and publications on catatonia. I guess the one that I would probably start with, and it is not for the faint of heart, but Jonathan Rogers did a marvelous job spearheading the British Association of Psychopharmacology's um, uh, clinical practice guidelines for catatonia, published about a year ago. And if you go there, see the guidelines, it has practice recommendations, what have you, just a treasure trove of references. I can say the American Psychiatric Association is currently working on a resource document as well, led by Joellen Wilson, marvelously for that as well. Um, and there have been a couple other recent reviews of note. The New England Journal published an article entitled, basically, I forget if it was just catatonia or catatonia something else, but it was an excellent, high visibility article. And there's also one other I'll mention is Nature reviews disease primers on catatonia. There was one on delirium several years ago, and it's kind of a counterpoint, if you will, on catatonia. Again, all of those are excellent resources. And the resource document from the APA should be out, we're hoping, later this calendar year.
APA is really pushing out those resource documents lately. The delirium one recently, now the catatonia one. You've been a busy man with them.
No, it's an honor to be a part of those, and they do a very thorough, rigorous job in kind of behind the scenes. You don't get to see all that, but they do an excellent job with producing those documents.
I will underline the British Association of Psychopharmacology guidelines. That article has become a Bible for me as a first year attending on a CL service. I talk about it until I'm blue in the face with my residents, with my medical students. I'm not a big link articles in the electronic health record guy, but when I see a patient with catatonia, especially if I'm rolling off service, I'm always linking that article to communicate with, especially like our intensivist colleagues, the primary team. These are the guidelines that we're following. So thank you for bringing that up. Those guidelines are absolutely magical.
Absolutely. By the way, you should be a citing guidelines kind of guy, citing references kind of guy in all of your notes. Cite
Beautiful.
it.
I will. I will. I often want to, but I don't know. I guess I'll talk about it with my psychodynamic psychotherapist, I suppose.
Okay.
Um, let's start at the beginning. Can you tell us about the history of catatonia? Any history that you think is important for learners to understand before we dive into the clinical presentation and management?
Sure. I'll keep this kind of brief. There are some kind of interesting historical tributaries to think about. I will say, schizophrenia research, the journal, the beginning of 2024, published an entire issue devoted to catatonia. They've had some pretty interesting historical reports from on catatonia from 1800 to the year 1900. They're you know the the syndrome itself was described by Kalbaum in the late 1800s. He coined the word catatonia. He originally used the letter K, kind of a German spelling, kind of like our EKG versus ECG, but we obviously use the letter C currently. Um, there is also a book on the kind of the history of catatonia by Shorter and Fink in 2018. I'll just mention, called "The Madness of Fear." Um, and yeah, I guess the other kind of historical thing to note, and this I'm sure will come up today as we think about kind of the place of catatonia in modern clinical practice, is historically, catatonia was understood kind of exclusively from the perspective of hypoactivity or hypokinetic presentations, kind of the kind of mute and akinetic picture. And at the same time, when Kalbaum originally described it, he was very clear that patients could vary and could have periods of, activation and excitement, psychomotor excitement as well. But for whatever reason, that idea that catatonia has to be the person who is not speaking, not moving, has persisted. And I think, unfortunately, that might limit our awareness of it. And then, kind of nosologically speaking, it was kind of under the umbrella of schizophrenia as a subtype of schizophrenia for many, many, many decades. And it really isn't until modern kind of DSM and ICD additions that catatonia could obviously be diagnosed outside the context of schizophrenia. In fact, epidemiologically speaking, it looks like catatonia, the most common associated condition that presents as catatonia, are mood disorders. So unipolar and bipolar, unipolar depression and bipolar disorder. So when we think about it, the construct has definitely expanded. We recognize it in the context of medical conditions. And final point about history, when it was originally described in these early presentations, early descriptions, even these early theorists recognized it outside of just as we now understand schizophrenia. And so it was understood to be kind of this syndrome that could exist in different contexts. So in some sense, although we are now moving into a broader construct of catatonia, I think we're effectively rediscovering what was already known but forgotten. There's a lot of amnesia that we have in catatonia, and we keep rediscovering it. And much of the rediscovering I'm going to attribute to Dr. Fink, who, just always keeps bringing us back and saying, you know what? It was gone. Really wasn't gone. It's here. Let's just pay attention to this thing.
Awesome. Now, the big question for you, an almost impossible task for audio format. I'm going to ask you to describe for us the features that we see when we make a diagnosis of catatonia. I am also going to shout out your videos from the University of Rochester. I think in terms of teaching my residents and med students, if you took the BAP guidelines and the Rochester videos, that's a solid 80% of what I'm teaching third year medical students about catatonia. The videos are absolutely brilliant. We will link them in the episode notes if you want to watch them as you go through this podcast. Dr. Oldham and one of his former CL fellows, demonstrate for us all of the different findings in catatonia. So I cannot give you a big enough shout out for that. Anything you want to say about the videos before I start pitching you symptoms?
Sure. Just a couple of things. Uh, I so we did that with Josh Wartzel. By the way, he was a resident when he was here, not a CL fellow, and he is amazing. So Josh is full of energy, and I was his assigned mentor through many of the years of his residency, and we knew Dr. Francis was going to be coming to do grand rounds, and we really wanted to capitalize on this and kind of make this into a product that we could really advance catatonia. And so in our conversations, we came to this idea that we would create these videos and we would evaluate them. And I told Josh very early on, and he's an actor. He does music. He kind of he yeah. So he's amazing. And I said, by the way, though, Josh, you realize that you're going to be typecast as that person who played Catatonia for like, I don't know, years to come. And he said, I'm game. So I said, if you're okay doing that, I would be delighted. So we had a lot of fun going through those. We nickeled and dimed every line with Dr. Francis. So we had a lot of fun making them. And I'm delighted that, that they've been helpful for people, just to identify this condition.
So, in the DSM, if we're making a DSM diagnosis of catatonia, there are 12 signs or symptoms that they ask us to look for. And the cutoff in the DSM, we're looking for 3 or more. I am going to pitch Dr. Oldham these signs and symptoms one by one. Let's start with stupor. How would you define stupor? What are we looking for here?
Sure. So I'm going to have kind of a background commentary about how I disagree with some of these a little bit as well. I'm going to acknowledge that at the outset because I don't know that their kind of parenthetical descriptions are necessarily ideal in every context. And this is one where that is true. So, stupor in the DSM 5, I have it here in front of me. In the parentheses, it says that is no psychomotor activity, not actively relating to the environment. And it doesn't have to be none. So this is on a spectrum of reduced global psychomotor activity. And so, yes, in its severest form, the person is simply, non-reactive, including to painful stimulus. That would be a 3 on that item in the Bush-Francis catatonia rating scale. But, marked reductions in an individual's global gross psychomotor activity would qualify, I believe, appropriately for a stupor / immobility if we're kind of using the analogous Bush-Francis catatonia rating scale item.
Let me go ahead and set you up then to clarify this for us before we go along with the DSM criteria. One of the things that I have noticed as someone who's not a catatonia expert that confuses me when I'm learning this, going through this, is the DSM and the Bush-Francis catatonia rating scale. They're not a 1-to-1. They don't line up 100% perfectly. Could you walk us through maybe some of the key differences that you see? And do you have a preferred diagnostic method when you're on service and you're sending your resident, you're sending a medical student to go do that initial evaluation? Do you lean toward the DSM? Do you lean toward the Bush-Francis? How should we sort of balance these two different schemas?
Sure. Good question. So first off, I've dived down the rabbit hole of I'll say kind of the phenotypic description of catatonia in an article from last year called "Describing the Features of Catatonia," and I explore each of these throughout all the diagnostic systems that have been proposed throughout the years that I was aware of, and kind of and in any modern context. So, if you want to see kind of a line by line, chapter and verse discussion of each of those, feel free to dive into that. I would say at the highest level, diagnostically speaking, we should use the DSM. I mean, that is the kind of those are the diagnostic criteria for clinical practice. So most factor analyses of catatonic symptoms suggest that we really should be thinking about this kind of from the level of at least 3. So 3 really is the appropriate threshold. The Bush-Francis Catatonia rating scale, says that it's actually broken up into the screening instrument, the first 14 and then 9 additional items to complete the full scale. And any 2 of the screening items was considered positive in the original publication. The interesting thing historically is nobody had exactly 2 items. There were people with 0 and 1, and then nobody with 2, and then everybody else had 3 or more. So technically, everybody in the original validation study had 3 or more. So even though that number occasionally shows up in the literature as 2 or more, it technically, for all intents and purposes, represents a cohort of individuals who had 3 or more. So I would say clinically, we use the DSM, and the ICD also. The ICD-11 also requires 3 or more. So kind of broadly analogous. The one thing I'll note about a true distinction between the DSM and the Bush-Francis is how we regard the term waxy flexibility. So waxy flexibility in the DSM is, and I'm sure we'll continue going through these as well, but is slight even resistance to positioning by the examiner. That is to say, it is kind of mild rigidity throughout the range of motion. So on the Bush-Francis, that would be scored as rigidity. Whereas in the Bush-Francis, waxy flexibility refers to initial resistance that releases shortly thereafter with passive motion. So unfortunately, this distinction goes back to different models of the idea of catalepsy and waxy flexibility. But for the purposes of diagnosis, though, I think the appropriate way to go would be to use the DSM.
That is wonderful to hear you name that distinction so clearly, because for years there's been times in my training where I just felt stupid. Like, I feel like I learned it as a third-year medical student, and I was like, this is what waxy flexibility is. It's even resistance to repositioning by the examiner. And I think of like a wax figure where you could just sort of reposition it and it would just move, slight even resistance. And then it felt like in another life I was told, no, 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 it's like the bending of a candle, because so many of us are bending candles all the time, where it's initially difficult, but it becomes easier as it gives way. And I just feel like I've been in a vortex with this phrase in my mind. So thank you for clarifying that. Per DSM, waxy flexibility, even resistance to repositioning by the examiner. Per Bush-Francis, waxy flexibility, initial significant resistance, which eases as you move the limb with greater amplitude.
Yep, I agree. Yeah. And I mean, clinically speaking, I'll just say, the first one we talked about was stupor. The next one on the list, which I'm just going to take it from you, is catalepsy. So catalepsy is, again, described here as passive induction of a posture held against gravity. So what that means is I can move somebody's arm, and when I let go, it stays, right? So I'm able to, it's like claymation, right? That you've moved the arm and now it stays. Now, the reason I mention that in the context of waxy flexibility is historically, this idea of waxy flexibility was a syndromal description that kind of encompassed both the slight even resistance and the fact that it would stay up after you left it. And when you start to move it again, it's like there's this initial resistance, but then gives way and becomes pliable, but then you let it go again and it stays. So, I mean, it is often that you see these all kind of at the same time, right? So one can easily, it's hard to imagine that there would be no resistance, and yet when you let go of the arm, it stayed. Clearly, there had to be some tonic activity for the limb to stay up in space against gravity in the first place. So again, these often co-occur, and I think that's one of the reasons that there has been some confusion over the term waxy flexibility.
Beautiful. So catalepsy is that maintenance of a posture against gravity. When I'm examining the patient, I might lift each of the four limbs off the bed against gravity, see if they stay. That's how I would check for catalepsy. Is that correct?
Yep, correct.
And clinical note from my work, one thing that's fascinating to me is sometimes I will see significant rigidity and or catalepsy in one limb and not the other limbs. So I would make sure we're doing a full exam here for passive range of motion testing, et cetera. Can you contrast catalepsy then in the DSM with posturing?
Sure. So posturing is something that the patient does spontaneously. So, you come upon them and they happen to be in a posture held against gravity. And again, the key here is against gravity. So it would not be posturing to be lying flat in a bed. There has to be some tone. It could be tone in the core as they are sitting in, a mundane posture for an extended period of time. But again, the core is engaged, and so that's keeping them erect from not falling down. So that the distinction really comes into how it begins. However, with posturing, you don't see how it necessarily begins every time, and so one could argue that maybe someone put them in that position, and now you're just seeing catalepsy, but you're seeing it down the road. So the Bush Francis does combine both of those. Posturing and catalepsy are the same item in the Bush Francis. I mean, one could make an argument for combining or separating them, but in both, there is, again, maintenance of a posture against gravity.
Very clear. Mutism. How would you define mutism for us per the DSM?
Yep. So it says here no or very little verbal response, exclude if known aphasia. And so this is actually notable, right? So it says no or very little. So again, it already includes the spectrum of decreased verbal output. And I think by analogy, we would expect that stupor should also have that spectrum kind of approach. It's not just no movement, but significantly reduced movement, I think should also qualify. But again, it's a reduction in verbal output overall.
Next up is the one of the symptoms that you sort of led with your story about negativism.
Mm. Negativism, honestly, when we were developing the resources here in Rochester, and we kind of created a coding guide for the Bush Francis, this is the hardest one to define, sincerely, because arguably many of the other items that we have talked about and we'll talk about represent a form of negativism. If I ask you to move your arm and you are not moving it, you are not responding to my instruction. That is a negativism right there, right? So, in some sense, it becomes kind of tricky. So, the way that I think about this is okay, just in this is opposition or no response to instructions or external stimuli. Again, I'd like you to speak to me and you're not speaking, but that's mutism, but it's also negativism, but it's not specific to my instruction. It's kind of beyond it. Negativism is when a person fails to do a thing that you have clear evidence that they can or should be able to do. So let's say you see them and they're opening their eyes, they're closing their eyes, they're blinking appropriately. And then at a certain period, they actually close their eyes and they keep them shut. And you say, all right, I'm going to try to open your eyes. Just be still here. And you try to open it and they clearly, oppose your attempt to do it. You know they can open their eyes. You saw them open their eyes, but they didn't, right? Or a person who is clearly able to move their arms and it's fine. And the moment you try to move it, it just locks. And it's like they are doing something to negate your movement, your interaction. It can also present, kind of globally speaking, when you ask questions and people give stereotypic responses of no or I won't. Clear interpersonal negativism to instructions, things that, again, they ought to be able to do, but they are, again, it seems almost reflexively negating it and not performing it. So we do add a clarification in our coding guide online that if the activity or finding qualifies for a different catatonic feature, it cannot also be coded as negativism. That's a tricky one. I'm not I that I would like a cleaner way of defining it, but that's the best way I can describe it currently.
Uh, that's one, especially, you gave a couple of examples. The eye opening, when you're trying to reposition the patient, they will seemingly for no reason really fight you on the repositioning. And that's one where when that happens clinically, it really is an amazing moment that kind of brings these words on the page to life. And I feel like once you've seen that one or two times, it's kind of like cogwheeling, where you read it in a textbook and I think, that sounds kind of interesting. I wonder if I'll ever actually feel that. And then you see it. And for me, it was relatively straightforward. The other thing that makes me think of, you were very clear that for the negativism, it has to be an activity that we would reasonably expect this person is able to understand the directions and do. And I think what you're kind of contrasting it there with is someone who is not able to attend to their environment enough, someone who has, let's say, delirium, who just simply is not able to pay attention to you, to understand what you're saying, to follow any directions at all. That would not be an example of negativism. Is that right?
Correct. Yeah. I mean, if the person clearly is inattentive and can't focus and really process what you're saying in any meaningful way, and you have no reason to believe that they could, again, based on the kind of the degree of confusion, then I think it would be in some sense unfair to call it because it could just be that they're not understanding that. And so perhaps you could come back and, evaluate a little bit later at a point that they might be a little bit clearer. But, admittedly, right, sometimes we just don't obviously know at the first evaluation. And so serial assessments can very often help clarify.
Next up is mannerisms. This is, I feel like the only mannerism that I've ever actually seen demonstrated is saluting passersby. So could you explain to us what mannerisms is? If you know why that is the example that is always cited, I'd be interested. And what are some other mannerisms that maybe you've seen or that we should be looking for?
Yeah, so mannerisms represent a kind of a bizarre way of doing things. So it says here, odd circumstantial caricature of normal actions. So the way that Dr. Francis often will describe this is it's odd the first time you see it because it's out of context. They're doing something that is socially kind of how should I put this? Uh, there is an intentional action that is being done that is appropriate. So they are they're giving social recognition in your example of saluting. They are acknowledging the person, but a salute is odd in that context the first time you see it. So other things might be I'm walking from here down the hall, but instead of walking, I only skip or I only walk on my tiptoes. So I'm doing a thing that is totally reasonable, but the way I'm doing it in context is odd. Another thing, we might see is somebody who is speaking in a very strange accent. That's not how they usually speak. I just remember a very just very memorable experience. A person with catatonia who was not British. The first time we met him, he was talking with a very British accent. And we called to get collateral and we mentioned that to the family because they were not British sounding. And they were like, no, yeah, he doesn't speak with a British accent. And we're like, okay, good to know.
Huh.
That is not his norm. And then when the catatonia improved, the British accent went away. Totally went away. So again, speaking appropriate, but with a British accent, that's an odd caricature of a way of communicating in English, in an American context, if you will. So it's out of context. It might be totally reasonable in other contexts, right? Saluting someone is totally reasonable in certain contexts. Tiptoeing is totally reasonable in certain contexts. Speaking with a British accent would be totally reasonable in certain contexts, given who the person is and where they are and what have you, right? But it's odd. And so I'll just mention here, there is a great historical term that, probably my favorite descriptor of catatonic features, bizarreries. By the way, the original paper that references bizarreries or includes it as a clinical feature doesn't really describe it well, but I think it's just kind of on the nose. I mean, when you see something that is extremely odd, and again, we're thinking kind of in this context of mannerisms and manneristic kind of engagement with the world, um, that you should be thinking about catatonia, because very often catatonia just seems peculiar. There's something off about it. And when you see that, at the very least, it should kind of raise clinical suspicions for catatonia.
Thank you. We will be on the lookout for bizarreries when we are assessing for mannerisms. Could you tell us about stereotypy?
Yes. So this, this is can be tricky to differentiate from mannerisms, and sometimes the two kind of go together. But this is, again, I'm just reading the DSM, kind of the parenthetical comment: repetitive, abnormally frequent, non-goal directed movements. And so here, this is non-goal directed. So mannerisms are goal directed. Again, you're doing something that is appropriate: walking, speaking, acknowledging somebody in the hallway. But here, this is not goal directed, and it doesn't really serve a purpose. So the way that Dr. Francis often will describe this, really helpful way that I found it helpful, is it's not odd the first time you see it, but it's odd in its repetition. So I might, rub my nose because maybe there's an itch, and I might do that. And that's not odd the first time I do it. But if I keep doing that every few seconds, that's odd. It becomes odd because there's no purpose being served by this repetitive, stereotyped behavior, which, again, the first time maybe it was, but it becomes clear that it is an autonomous thing that is being done an inordinate number of times.
Often, maybe picking at clothes, rubbing hands together, things like that. Agitation not influenced by external stimuli.
Sure. So agitation is, I think we could kind of juxtapose this with the stupor one. So stupor is just, not a lot of behavior, kind of movement, movement, globally speaking. This is the opposite. This is way too much movement, kind of broadly speaking. And interestingly, it doesn't even give a parenthetical description here. But if you look at the Bush Francis, I think it's really helpful to think about it this way: extreme hyperactivity, constant motor unrest, which is apparently non-purposeful, not to be attributed to akathisia or goal-directed agitation. So I think broadly, this is when somebody does not sit still. They're constantly moving up and around and can't sit still in their chair, and they get up and they walk around, or they're moving things or engaging with the environment. It can become, kind of frankly agitation, like in the context of being violent, right? It can become that, and again, it just doesn't really serve any purpose. So again, it would be the opposite of stupor.
I think this is a reason that family members will often bring a loved one to clinical attention, is they will say, this person is awake all night pacing the halls. They won't stop
Yep.
moving. They haven't slept in a few and I feel like mania is kind of on the differential, and then you have to use your clinical acumen to understand this is not increased goal-directed activity. This is just constant motion that won't turn off. And another reason that having a high degree of suspicion for catatonia is so important. Grimacing is one that I have found really remarkable. I don't know if I shouldn't use the word pathognomonic, but definitely there have been times where I have walked into a patient room for the first time and went, oh, this person's catatonic because the grimacing is so clear. Tell us about the grimacing.
Sure. So grimacing, when I originally learned about this, the term that always kind of came up in texts was Schnauzkrampf, which literally means nose cramp, I believe, in German. And so it's just kind of a puckering of the face and the nose. And it was just kind of a sustained, almost posturing of the face, if you will. But it actually goes beyond that. So it doesn't simply have to be a fixed motoric expression on the face, but it can be. It can also include, stereotypic movements of the face, and typically, at least from what I've seen clinically, it involves kind of muscles in the face that are involved in social communication. So the mouth, the nose, like just kind of an eye expression, something that is very memorable and very you can't miss it kind of thing. I'll say I don't entirely know why grimacing is separated out from the other motoric expressions elsewhere in the body. that is kind of a curiosity in my mind historically, why it's been cordoned off as a discrete finding that can be identified in addition to all of these other motoric findings, which would be called, again, stereotypy or mannerism or posturing, catalepsy in other areas of the body. But yeah, if any of those happen in the face, it's grimacing.
Perfect. And then echolalia and echopraxia.
Echolalia and echopraxia. You're welcome. I just echoed you. Um, so, so these are both types of echo phenomena, and they are exactly kind of what you would think that they would be. Echolalia is repetition. So somebody says something in the environment and they repeat it. So the most striking example that I have ever kind of encountered of echolalia was, several years ago when I was at Yale, I was evaluating an older gentleman. He was in the room with a family member, and every time either I or his family member said something, he echoed it. He was like, "Is there an echo in here?" Yes, there was. He echoed everything we said. We had to actually step outside the room so that we could have the conversation without that interruption of echoing. And so, it could either be here it says, echolalia in the DSM mimicking another speech. In other contexts, it'll say the examiner's speech. But I think any echoing of speech should qualify, right? So you could hear it on the TV. A person's echoing what's on the TV or echoing what they're hearing in the environment. That's echolalia. Echopraxia is similar, but it's behavioral. So it is mimicking the movements of another person. And so to elicit that one, we say in the Catatonia exam, do something that might be a little exaggerated to see if they will do it, again, kind of mirroring your activity. So a classic way to do that might be to scratch your head in a very exaggerated way, not just a little scratch, but like do it and do it for an extended period of time to see if they will mirror. If they don't do that, then okay, simple as that. Other examples might be if you're examining a person who's standing up, you might turn in a circle and see if they turn in a circle, or do other kind of, again, behavioral activities to see if they copy it. When it happens, though, it's usually pretty obvious. It's not usually I wonder if they did. It's usually pretty striking, and I would say that I've done kind of literature searches to see, like, are there other conditions that present with echolalia and echopraxia? And there aren't really other things that cause echopraxia or echolalia. When you see that, I mean, I'm not going to say pathognomonic, but like you'd have to really have a strong argument why that's not going to be catatonia if they have that finding. Again, it would be extremely rare outside of a catatonic presentation.
Perfect. Yeah, it's definitely one of the things that we assess for that when it's positive, it's just so striking to me. I'm like, how am I so lucky to get to, or so blessed to get to see this amazing sort of work of nature? Like, why does this exist in the brain? How does it work? Outside of this context, no one would get to see it. The human brain is certainly endlessly fascinating in that way.
hmm I agree with you.
I'm going to give you one kind of final open ended question on the diagnostic signs and symptoms. The Bush Francis has plenty of signs and symptoms that are not included in the DSM. Again, we mentioned there's 12 in the DSM, there's many more in the Bush Francis. Are there any other signs and symptoms from the literature, from the Bush Francis, that you think, in order to do this justice at the bootcamp level, we absolutely have to talk about this?
Hmm. I mean, I'll highlight a few. I don't know that I'm not going to say much about these, but I'll just highlight the other items that are on the screening instrument, just because I think those are the ones that, if I'm clinically going to work with a resident or a med student or a fellow, what have you, and say I did a catatonia exam. If you haven't done at the very least the screening instrument, then in my mind you probably haven't really done an adequate exam personally. So a couple other ones might be staring. So increased, I'll say decreased blinking or kind of fixed visual gaze, a decrease in scanning the environment. Verbigeration is what's been kind of described as scratched record speech. This is essentially a stereotypy of speech. So I thought I went, I thought I went, I thought I went, I thought I went. And it's usually in the same cadence too. it's 5 o'clock. It's 5 o'clock. Someone said that the other day to me several times. And I was like, that's not right. And so it was a clear instance of verbigeration. We already talked about rigidity a little bit, right? So waxy flexibility in the DSM is, technically just a type of mild rigidity. It is called rigidity on the Bush-Francis. And then the final one I'll mention is, and just for clinical kind of purposes, withdrawal, really important for overall health and well-being, right? People who have catatonia very often will not eat or eat enough or drink enough. And you could even, try to feed them, with the spoon, and like they'll just turn their head, like they just won't do it. Um, so withdrawal, I think, is really important because, as we're going to talk about later, I'm sure, the implications of catatonia, why it matters medically speaking, is a person with catatonia is not tending to self-care. They're in a very vulnerable clinical situation, and they're not able to just will themselves out of it. And so ensuring that we provide adequate nutrition, hydration, what have you, I think is absolutely essential.
Thank you. We will get to that. We will prime our listeners to think about if you have a patient who's not eating or drinking, who maybe has electrolyte disturbances due to that. They're also not moving much. They're very immobile. Think about what's going to end that patient's life ultimately, and we'll talk about it here in a few minutes. One key recommendation from the BAP guidelines that really stood out to me that I want to ask you about, and I've read this in, I think, just about every guideline I've read on catatonia, is that clinicians should interact with the person as if the person is able to understand what is being said, even if the person is completely stuporous and mute, etc. What's the reason behind this key recommendation?
Because they might be fully aware. I mean, in general, as a general rule, even a person has, delirium, I'm going to interact with that person as I would appropriately with any other person, right? This is just dignity. This is basic respect. We ought to always treat patients with the utmost respect. It really, I was going to say, it grinds my gears. That's hilarious. It grinds my gears though when I see teams talking shop in front of the patient as though they're an object. It's very objectifying. And I don't like that at all. I mean, I think we should always, when engaging with patients, interact with them, give them explanations, give them the dignity of, an appropriate interaction. So I think it's just really an issue of basic respect. There's a really kind of memorable story that I was told in residency where that really drove this point home for me. One of my attendings said they were an attending on an inpatient psychiatric unit, earlier in their career, and there was a gentleman there who had catatonia, and he had posturing. His arm was kind of up in the air, and this was really before they. And I want to say it was kind of schizophrenia with catatonic symptoms, and so it really wasn't as responsive to benzos, and really had a difficult time treating this individual. And other patients on the unit would actually make fun of this individual and use him as a coat rack, and like put
Mm.
things on his arm like it was a coat rack. And he couldn't engage. He didn't know what to. He couldn't say please don't. I don't appreciate that, and advocate for himself. And this would happen when no staff was around. And after the catatonia relented. He went and attacked the person who had been making fun of him because he remembered clearly what was being done, but he simply could not respond. Um, I have had so many patients, after the catatonia remits, after it resolves, remember many things that happened during the episode of catatonia. Even in the moment, I think they had kind of an anosognosia of deficit. They didn't realize that they were unable to move and why it felt weird. But they very clearly remembered instructions, engagement, comments from clinicians, recognized people facially, like, oh, yeah, you were here yesterday, but it was a really weird time. I'm not really sure I understand it all. So they do remember. Very often people will remember. So I would just say, especially in catatonia, everywhere for sure, but especially in catatonia, always engage with people as though they can understand you because very often they can, even if they're not engaging with you verbally or interacting like you might expect.
Yeah, one of the kind of underlying physiological theories for catatonia is this aberrant response of the autonomic nervous system, this fight or flight freeze response. And in a lot of the patient encounters that I've had, the patient really looks objectively terrified. Like I look into their eyes and I think this individual is deeply suffering and horrified and just has no idea sort of what's causing them to be so sick. And I think from the context of being a healer, being extra courteous, extra caring, extra humanistic and caring for these people, because subjectively speaking, I think this is a really, really terrifying experience. And so, um, I definitely think being extra humanistic with this population is really important. How common is catatonia?
I wish we knew. So there are a number of studies that, report epidemiological kind of data, looking at healthcare systems and people who have, documented catatonia diagnosis or, in healthcare systems where they've done Bush-Francis catatonia rating scales, and you can kind of query those. The reality is all of those data are insensitive. So the short answer is I don't think we know well what the rates are. I think the best review of the data is from 2018, from Solmi and colleagues, and they break it out into inpatient units, outpatient units. Outpatient clinical settings, and they report all different numbers. I don't even really want to put an anchor down because I honestly don't know. And honestly, I want there to be better research in this. And we know that it is far more common than than is being diagnosed. I can tell you that. I talk about catatonia all the time, and since I've come to University of Rochester, I hear people talking about catatonia relatively frequently now, and I'm not even seeing they're finding it. It's out there. So I would encourage our listeners to consider catatonia on the differential when anybody has, markedly reduced, markedly elevated, or abnormal motor behavior. Again, kind of the peculiarities that they might exhibit.
Respect. I will. I appreciate your expertise on that. I will not interrogate you further to have you give me an integer to represent the prevalence of catatonia. And you led us into my next question here. So there are three different motor subtypes for catatonia that we talk about: hypokinetic, stuporous, hyperkinetic, and parakinetic. Could you paint a caricature of hypokinetic catatonia for us?
Sure. So this is the person. So this is, I think, when most people think of catatonia, this is the classic presentation of catatonia. They're not moving. They're not engaging. They might be staring, or their eyes might be forcibly closed. Right. They're not eating. And so this is the individual who, you think about in the awakenings. When they get, people kind of come to wake. They come awake after being given something like Ambien, right? But the idea here is they're not engaging. There's not a lot of movement.
Hyperkinetic.
Yeah, so hyperkinetic is the opposite. So people with hyperkinetic catatonia tend to have excessive motoric activity, and it's when people, and I'll just kind of throw this out, kind of as an interesting clinical kind of observation, right? When somebody has hypokinetic catatonia and you give them a benzodiazepine, now they're liberated very often, not always, but very often they're liberated, and now they begin to exhibit kind of a broader range of catatonic findings. Previously, they were kind of inhibited, but now they're kind of able to express those. So hyperkinetic, though, would be, when people are really active, they might be combative. They may have a number of other kind of motoric expressions, like the echoing that you might see, or they might be, demonstrating stereotypies or mannerisms, things like that.
And then when I sent you the note for this episode, you altered this. I had not heard this as a descriptor for catatonia before. Parakinetic is the third motor subtype. What is parakinetic catatonia?
So, yeah, so parakinetic would be somebody who is not hypokinetic. So they're not, mute and immobile. They're not moving way too much, constant motion, just a swirl of activity, but they're somewhere in between, motorically speaking, and they're exhibiting the peculiarities of catatonia. So again, they might be having some of the things that you would see in hyperkinetic, but they might be having the echolalia, the echopraxia, the mannerisms, prominent stereotypies, things like that, maybe some grimacing, some negativism in the midst of that interaction. And so in that way, they're exhibiting these classic features of catatonia, but they're on neither of the extremes of motoric activity. And notably, it can fluctuate. So it might be one time of the day that you see somebody and they are, truly stuporous. And at other times of the day, they have these periods of hyperkinetic or parakinetic activity. And again, this can vary. I will say, just in talking to several people who are kind of in the kind of catatonia scholarly field, we don't have a lot of great data on the natural daily diurnal variations of catatonic features. I know there's some people who are working on it right now, but we don't have great data on that. So a call out to any of our listeners, our audience who is engaged or interested in this. There are so many, I would say, foundational questions that we have not answered. So if you're interested, dive in, please.
And what about malignant catatonia? In my brain, that's also one of our subtypes that we need to have a high index of suspicion for. Certainly keep in mind, anytime we see a catatonic patient, I think malignant catatonia should be on the front of our mind. What is malignant catatonia?
Yeah, so malignant catatonia is catatonia with prominent, clinically actionable autonomic abnormalities. So I was part of a group led by a med student at Vanderbilt, Jennifer Connell, and also Joellen Wilson there. And we wrote a review of malignant catatonia for the intensivist because malignant catatonia is a medical emergency, and in most instances really should prompt higher level of care, ideally in a critical care setting, because it can be fatal because of the autonomic dysregulation. It's just unsafe clinically. But essentially, it can be things like extremely high blood pressure. It can be extremely low blood pressure. It could be fever. So fever is a very common finding there. But people can be sweating profusely. But malignant catatonia, few notable facts. One, it can happen with any motoric expression. So you can be stuporous, hypokinetic, you can be hyperkinetic, you can be parakinetic. The motor activity does not determine whether it is malignant catatonia. If you have catatonia, plus add to that these kind of air quotes malignant features, namely the autonomic dysregulation, the abnormalities, that is the malignant catatonia. There are some kind of I'll say discrete causes of malignant catatonia. We think of NMS as neuroleptic malignant syndrome as a kind of a subtype of malignant catatonia. People who have autoimmune encephalitis, like anti-NMDA receptor antibody encephalitis, can present with this catatonic syndrome and autonomic dysregulation. So again, this malignant catatonia type presentation. And malignant catatonia can be dangerous either because of the underlying cause in the case of autoimmune encephalitis, but it can also be dangerous simply because of the import of the autonomic dysregulation. And that itself can be devastating. So when you see that, it is something to kind of to treat very assertively and be very cautious, because people can turn the corner and begin kind of deteriorating clinically very quickly.
When I first discovered the school of thought, I don't even know how to put that. When I first read that NMS is a subtype of malignant catatonia, I vividly remember, it felt like the scales were lifted from my eyes. I was like, it really helped me to understand both presentations a lot more deeply, a lot more conceptually, I think. So that was really, really clarifying for me when I initially encountered that idea.
I do want to add to that. I think the fact that NMS is a subtype of malignant catatonia also leads people to think that, hyperkinetic catatonia can't also be malignant. Like they get the sense of like the rigidity, so they're not moving, and it's just the hypokinetic form. So I want to be very clear, right? You can have any motoric expression. I know I'm repeating that, but I think that's an important learning opportunity here. Like any motoric expression of catatonia can present with malignant features. These are individuals who clinically tend to require much higher doses of lorazepam for clinical effect. And this is the context where ECT should be pursued urgently, if at all possible, because it can prove life-saving, liberating for these individuals.
And as we begin to talk about ECT, listener, we are going to stop there for today. We're going to pick up next week with the management of catatonia. So look forward to talking about lorazepam, ECT, and all things management of catatonia next week. Thank you for joining us for this episode, and we will talk to you again soon. Thanks for listening to this episode of Psychiatry Bootcamp. If you enjoyed the podcast, please take a minute to leave a review on Apple Podcasts or a rating on Apple or Spotify. You can reach me at psychiatrybootcamppodcast@gmail.com. Find me on TikTok or Instagram at Psych Bootcamp. Our theme music is by Cave Radio. Special thanks to Matthew Braddock for production support. The opinions shared on this podcast do not reflect the opinion of any institution, including host or guest employers or podcast partners. This podcast is not intended to be used as medical advice or in any legal proceedings whatsoever, including to establish a standard of care. This podcast is intended only as a supplement to a complete, accredited psychiatry residency and is grossly inadequate to rely on for medical decision-making. It is intended to entertain and inform. You should always rely on your own clinical judgment when making medical decisions and contact your physician for medical advice. This is a Human Content production. Hey everyone, thanks for watching. If you enjoyed the show, please remember to subscribe to the channel. If you'd like more episodes, you can click right here. I'd love to connect with you more, and I'm looking forward to talking to you next.